eye. So we like talking about people who have this because when we see it, it's too late. That bone is actually changed. Those lower ribs are flared. That belly breathing produced a flare. That's a singer. They can get the air out with extension. They pull the air in with their neck. They get the air out with extension. They pull their air in with the neck. And they develop these little grooves, these Harrison grooves, these little flares. We use a spirometer that we have laying around here. I see it. We use a spirometer that comes in all shapes and forms. I'm not promoting this spirometer, but we happen to be using this one, about $200. And we measure whether or not an individual has less or more amount of air coming out when they exhale. We would like to see their exhalation values increase if they are hyperventilatory, because they've got a lot of air in them. So when we look at norm, we like to say, hey, that's norm. You got so much air in you, you got to give me another 300-400 cc's. You got to get it out. Our techniques, manually, non-manually, are focusing on exhalation phase. And then when you breathe with your diaphragm, we're going to maintain a position to enhance inhalation with a non-puller, with the diaphragm. A different kind of a puller, but not a neck puller. So this singer has 37 years of age, has 3,800 cc's and no ZOA. And I don't want to say no for sure because I don't know if it's completely flat, but I have my suspicion by looking at his rib cage. And look at the convexity. Pectuses are just prevalent in the world on one side or both, these little concave chest walls. So here's our treatment. We did some two-person manual techniques on this individual to enhance, listen closely, you don't know what we're doing yet, you will tomorrow, alternating chest expansion. Kurt, air in, air out, air in, air out. By providing opposition to those flares, those last true ribs, to promote good quality zones of apposition so the diaphragm can contract and expand pleural pressure in a negative system, negative pleural pressure. And when that air is being drawn into the negative pleural pressure, what does that chest wall got to do? It's got to expand. And mechanically, we're going to take this car jack and this crowbar and help it. The ribs are at an angle. They're at an angle for a reason. They have an angle here to help open you up, to jack up the system, to increase volume. So we did that. And we're now, I can't tell you exactly what phase of the program I'm in, but between these two hands, we're directing airflow back and forth. So that's all we're doing. Now I have this hand and this hand are on top of each other to maintain ZOA primarily on which side? The left side. This hand and this hand are there to enhance expansion and distraction. All this is in your manual by names, terminology, and I promise you we will go over it. It's called an intercostal technique with opposition on the contralateral side. So Rick, all we're doing is taking this person and we're making sure that air can become more easily appreciated on the right side while the left side is being maintained in a good quality state of apposition. Through opposition of two hands on that last true rib segment. Opposition maximizes apposition for contralateral fill. Does that make sense to everybody? Apposition is maintained and maximized through opposition on that left side for contralateral expansion, enhanced by my two hands on the right side. And after we got done, he could only get 1,500 cc's out because we got it all out. So his hyperinflation improved. And now he's in a normal range. He just took a deep breath in, Jonathan, and blew out. Gave me only 1,500 cc's. We cut his volume by half. Makes sense to you guys? So is that a healthier thing or a non-healthier thing? To go from here to here. That's a super healthy thing. This guy can breathe. Every time he takes a breath in, he's got all this tissue that can exchange. He's got alveolar tissue that he wasn't even using, now he's using. And he's going to get up, and the first thing he's going to say, Heather, whoa, brain freeze. Whoa, that's called lightheadedness, because I've got so much lift. My balloon, you ever see the movie Up? Whoa, I need to be tethered. Hold me down, because I feel lifted. I feel lighter. We've got some really good emails on this, don't we, on the internet? Did Mike write one on lifting, lighter? Or am I imagining that? You feel lighter. You feel like you're floating. And then therefore they don't have to work hard to breathe. Next thing you know, they're getting a rush. I have to say, hey, Brianna, slow down. Slow your breathing down. Okay. Don't breathe. Only breathe when you have to, Heather. And you'll start to feel better. Because they got all this power. They don't want this energy now. I hope this helped. So this is a 17-year-old baseball pitcher, right shoulder pain and severely limited right HGIR, which we will go over. The dad has helped him do some two-person manual techniques where they were guiding the ribs down for 2 breaths only 2 breaths. So he was, before treatment, he looked like that. And then after treatment, you can't see much of a difference. But after treatment, he had full HGIR and no shoulder pain. And Jen, I don't know if that picture was meant to go in there because of limited HGIR. I didn't see it.
Yeah, this is Mike Cantrell's patient.
Yeah.
And he just said the dad is standing in that second picture, but he said he had the dad help him with this technique, and the son said he flipped the pictures just to kind of give you a better visualization. But he said on that right side too, after treatment, you can see, that prominent rib cage sticking out in your face, and then. He could breathe, he could rotate his shoulders, he had no pain.
Just with 2 breaths.
Kind of a teaching.
Yeah. His point was with 2 breaths, his son's baseball arm could fully internally rotate. After 2 breaths is why I left it in there. So in other words, the message is from Mike is that if you have people who are limited in arm appendicular function, here's a good example of a clinical demonstration of what airflow can do to enhance that osteokinetic and arthrokinetic activity level, right? That's the message. Atypical hyperinflation, this is all atypical stuff. This is something you do not see. I threw it in this course so you know that I always get kind of excited about the things that are very atypical. This is a person who has diaphragm paralysis on the right side. I won't go over the entire history, but I will say this too, this is a fact. This person had 22 sessions of upright cervical traction the month before, 22 3 times a week. That'd be about a month before this picture was taken. There was a big lawsuit. It was carried out in a clinic, a physical therapy clinic. Cervical traction pulled the diaphragm's attachment site neurologically off, so the diaphragm became paralyzed. So it made history. That's why you don't see a lot of cervical traction being promoted these days a lot. So cervical traction 22 times in about a month, 3 times a week, created this. They had before and after images. I only got the after images. The reason I got that is because I was an expert witness for the case. So this is a true story. You do not want to pull on things that are already being pulled on, is the message. Take home message. Why would you pull on a neck when the neck is already being pulled on? The problem is this person could not get air on which side? The right side. They had nerve tingling and tenderness. First thing you do is want to distract the neck. Makes perfectly good sense. But when you tip a chair back and you put them in flexion with occipital pull, you're going to pull. It's going to be a great pull. But if the breathing that was going on during that time was in a state of what, everybody? Extension. Something's got to go. This time it was the right diaphragm. Secondary to seated cervical traction. This happened about 15 years ago. Very, 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 very not good case. Message is, before you pull on the neck, make sure you have a ZOA. That's a take-home message. Okay? You can be born without a right lung. This guy was a patient of Jason of mine. He didn't have a right lung. But we didn't stop trying to do what on the right side? Mike, we didn't stop. We still try to maximize right intercostal. He doesn't have any lung, but we didn't stop getting side bending to the left. He doesn't even have a right lung, and he felt better. He really needs, Chad, kind of going to you today with the abs, this guy really needs how to find left ZOA. Even though he doesn't get air on the right side, he's still got to get air on the left side with a good left what? ZOA. I should, for the record, for the course, remind all of you that when the left rib cage, when the left diaphragm, hemidiaphragm contracts, air goes into both lungs. But air will go better into the contralateral lung the more ZOA you have established on that left side, which is what you want. Air going only on the ipsilateral side does not make you ventilatory effective. It makes you ventilatory efficient on the left side only. That means you don't shift. That's not going to help you out. So we really want to maximize ventilatory efficiency on the contralateral side of the zone you're going after. So you can shift when you walk and when you move and rotate a spine that shouldn't get locked up at that point. Just repeating that again. This is pretty atypical when you see a chest wall on the right side flared more than the chest wall on the left side. In other words, she's got a little bit of a flare on the right side, where normally you see the flare tessa on the left side. When you see something like this, your wheels should be spinning. That doesn't happen every day. First question I would have for you is, do you have any brothers? Do they sit on you? What happened? That's trauma. And she had some trauma. Very, very normal looking right chest that's not expanding, but this is not normal. This is normal. This is what you should see. Left flare more than the right flare. That is very normal. Okay, shortness of breath, short, tight subcostals and intercostals. We've covered a lot of this morning, but for completeness, it's in your manual. I mentioned earlier that you could have these strong forward, posteriorly rotated craniums. Forward head posture is accompanied by most of these symptoms. You'll see people that paradoxically breathe, which is a word for incorrect breathing. The rib cage depresses or moves in the wrong direction during inhalation. In other words, I'll demonstrate that for you. If you take a breath of air in, the chest should expand. We'll show you some pictures coming up. If you take a breath of air in and the chest collapses, in other words, you collapse, you know you're extending. If you blow out the air and your abdominal wall, as you blow out the air, doesn't come forward, but is actually going back, you know you're doing it wrong. You're forcing air out with the back versus forcing air out with the abdomen. If you force air out with the back, ribs are going to go up, ribs are not going to go down. That's paradoxical breathing. Paravertebral used upon exhalation is a very, very common occurrence in society. Circle it about 3 times. Make sure you understand it. That's this. If you use your breath incorrectly, not this way, if you use it incorrectly, you're going to see a reflection of that when you put a person on their back. Here's an individual laying on his back. He's taking a breath in and he blows it out. Both the chest wall and the abdomen should be going down. Both of them should be going down. This is paradoxical exhalation.